The presentation is entitled Tyrosine Kinase and Immune Checkpoint Inhibitors to Treat Hepatocellular Carcinoma Pre and Post Liver Transplantation. And my identification follows that with my name, professor, and address and so forth, which you can obtain through the meeting people, since we can't get my slides up. The first slide identifies the problem that I'm to address, and we all address. And the first issue is that the liver is a highly immune tolerant organ. So whatever we do, we have to recognize that it's tolerant, and that creates a problem in terms of control of the tumor and so forth. Thus, it's often the focus of chronic infections, tuberculosis, hepatitis B, hepatitis C, other infections. It's also highly susceptible to toxins that cause chronic inflammation and fibrosis that can progress to cirrhosis and/or cancer. Despite all of this liver's intrinsic immune tolerance, successful liver transplantation requires additional immune suppression. So the patients that we see, and the problem I'm to address is hepatitis or hepatoma in an allograft liver. So the patient now has a tolerant liver. He's on immune suppression, in addition to having intrinsic tolerance. And he'll need more immune suppression in order to get rid of the tumor or control it. Thus, surgeons and physicians, oncologists, everyone caring for transplant recipients have to consider the effect of their actions to either decrease or increase the existing level of immune suppression in order to maintain both allograft and patient survival. So the next issue is, how do we assess immune tolerance and the degree of immune suppression? Well, the mean difference in the requirement for exogenous immune suppression required for successful transplant of any allograft is defined by the mean difference in requirement for immune suppression of the non-tolerant allograft, such as heart or lung, and the level of immune suppression required by the tolerant allograft, the liver. That is, the previous two organs require much higher immune suppression than the liver, and that difference represents the amount of space that's available for additional exogenous suppression, as we need for patients with a liver graft. Thus, the mean level of intrinsic immune tolerance can be estimated by that difference. The smaller this difference, the greater the immune tolerance of the organ in question. The greater that intrinsic tolerance of the organ is, the less exogenous immune suppression is required, as evidenced by what we do with liver transplants. So we have two options when we see these patients: to continue the current level of immune suppression and utilize standard level of immune checkpoint inhibitors to eliminate the cancer that's in the allograft, or we can maintain the current level of immune suppression and reduce the usually accepted level of the immune checkpoint inhibitor. Choice B, that's the second one, continues to protect the allograft from rejection, but reduces the possibility that excessive enhancement of the immune activation will induce immune recovery with the development of severe uninhibited immune mediated disorders, as we've just previously heard about, and adversely affect tumor growth, which can grow and thereby affect the patients. Identifies the pharmacological tools that activate the immune response to reduce tolerance and induce tumor control or destruction. And there's a whole list of them. including PD-1 and PD-L1 monoclonal antibodies, all of the TK inhibitors, VEGF, CTLA, TIGIT blockade, and the standard ones that we know about. So, but that's only a short list. There are a variety of other things to do. Well, what about the immune checkpoint inhibition issue? Unregulated PD-L1 activation enhances T cell replication and results in T cell exhaustion and a very poor cancer prognosis. PD-L1 monoclonal antibody blocks PD-L1 signaling and restores T cell responses to include T cell anti-cancer activity. A meta-analysis of 23 of 1,217 articles were reviewed, and they looked at what happened in these cases, which used either an anti-PD-1 or PD-L1 inhibitor. And the overall response rates that they achieved in management of the cancer was 28 out of 1,232, or 1%, and the continued growth of the tumor occurred in 33% of the patients. Now, if you use the second one, the complete response was only 2%, and the 32 of the patients went on to have continued growth of the tumor. Adverse effects occurred in 63% of these patients, occurring in 18 with fatigue, rash, pruritus, and an increased AST in 16%, and an ALT in 13% of the individuals. And that's important for, in terms of what your next move is in terms of the liver possibility. So now let's revert back to PD-1 and PD-L1 inhibitors and their current, their use in recurrent HCC. Historically, PD-1 and PD-L1 inhibitors have been excluded for treatment of recurrent HCC occurring in liver transplant recipients. So there's been a block. The fear of allograft rejection, immune-mediated allograft hepatitis, and allograft loss are all the reasons for this prohibition. I'd like to point out that as a former president of the United States said, this is fear for the sake of fear itself. And we shouldn't let this inhibit us from trying to move forward. If one can assume the fractional immune suppression produced with the use of rejection medications currently in use, one can estimate the amount of additional immune suppression an individual can tolerate safely with the use of a PD-1 or PD-L inhibitor, assuming the current guidelines for safe use and the agents are known. And so it's clearly possible. The next question is, what is PD-1? Well, it's an immune checkpoint protein expressed by T cells and B cells, as well as macrophages. And it's co-expressed with TIGHT, T-I-G-H-T, on CD8 positive T cells that produce interferon alpha and gamma. The adverse hepatic manifestations of immune checkpoint inhibition therapy is to produce hepatic injury, identified by increases in the serum transaminases, but do not directly adverse hepatic function. And that was one of the point I wanted to make, is abnormal liver tests that people measure is ALT or AST, and they actually measure different things. ALT measures hepatic injury, while AST talks about actually suppression of function. So it's dysfunction is AST. And so ALT is acceptable, AST is not acceptable because it leads to graft failure. Overall, the immune checkpoint inhibition adverse reactions occur less often and less severe than those that occur in other checkpoint inhibitors, such as CTLA-A, which I think is probably among the worst. Now, the next slide that I was to bring up identified the various checkpoint inhibitor therapies that you all know about: tyrosine kinase inhibitors, monoclonal program death inhibitors, and anti-PD-1 and CTLA-1 and anti-CDL-1 by itself. So they were all listed for you, but you can probably get a copy from the meeting of people. Now, the historical clinical experience with checkpoint inhibitors in individuals with cirrhosis has been examined several times with, and I don't know how to pronounce many of these monoclonal antibodies, there's too many letters, but tremelimumab, 15 milligrams per kilogram for 3 months in 21 patients, all with hepatitis C. They reported disease control in 76.4 of the cases. The median time to disease progression was 6.48 months, and the median survival was only 8.2 months. That's presumably a big deal with oncology, but it's really not very big in other fields. And they used tremelimumab antibody in the patients that have been receiving ablation therapy in the past, radiation therapy, TACE, and so forth. And they claimed disease control in 89% of the cases, which is spectacular. And the median survival now jumped up to 12.3 months. So that was very positive. If they use nivolumab and they treated at a dose schedule starting at 0.3 milligrams per kilo to 10 milligrams per kilo, the upper dose that they used, their objective response occurred in 15% of the cases. 31 were treated on a fixed dose of 3 milligrams per kilogram every 2 weeks and obtained an objective response in 20%. So it looked as if escalating dose worked less well than a fixed dose. The problem with that understanding is that the existing tolerance or existing escalating schedule only went up to 10 milligrams per kilo, and the group that got a better response was receiving 50% more therapy. And so I think this does not suggest that immune blockade is adverse to the patient. And so both groups got durable responses, but if you use a larger dose, you got more, which reiterates what the president said: fear for itself isn't going to help anybody. We next looked at articles that looked at anti-VEGF with or without program death or program death 1 therapy. And they found that with the program death group, 1% had a complete response. Progressive disease occurred in 17%, and the overall response rate was 17%. If you look at the PD-1 group, which did, quote, better, they had a complete response in 2%, which is a 100% increase, but it's a very small number. And the disease progression dropped from 17 to 14%. The sustained response, however, only continued in 43% of the patients, and the overall response rate was 15%, which is better than the 17% with the PD group. Adverse effects occurred in 13% of the patients, and Grade 3 adverse events occurred in 18% of those patients. And the major complaints were fatigue and pruritus and abnormal liver enzymes. Now, what about TG blockade for hepatocellular carcinoma? Well, TGIT is a molecule involved in inflammation, fibrosis, adaptive immunity, and cirrhosis, and tumor progression as a result of adaptive immunity or tolerance directed at the inflammation, fibrosis, and tumor-promoting mechanisms that exist. TGI binds with high affinity to the poliovirus receptor, which increases secretion of IL-10 and suppression of IL-12B, T cell activation, and the generation of immunoregulatory dendritic cells. CD155 is a TIGIT ligand and member of the nectin-like family, and it's associated with inhibition of T cells, NK cells, antigen-presenting cells, as well as tumor proliferation and T cell exhaustion process that promote tumor growth and or proliferation. Well, what are the main adverse reactions to immune checkpoint inhibition? Well, with PD-1, the most adverse was a reaction called hepatitis, and that occurred late, meaning 4 to 6 weeks after the initiation of PD-1 therapy. Most cases with ALT or quote hepatitis reactions are asymptomatic. The frequency is dose dependent, occurring at 3 to 4% of a dose of 3 milligrams per kilo, increasing to 15% at 10 milligrams per kilo. And that's for reference to how the doses that were used in the escalating study, showing that escalation didn't work as well. Well, that's because they didn't receive as much immune suppression at the top level of their escalating dose. Now, how do we distinguish an abnormal transaminase that suggests injury or dysfunction? Well, we already know that ALT measures injury more than anything else, but the AST measures dysfunction. Now, people wonder what that means. What are we talking about? Injury or dysfunction? When I give lectures to my hepatologists, I say, well, let's imagine that the liver is the Mercedes that you drive. All right? Now, if I take a sledgehammer and go out and beat your Mercedes so that it just looks horrible, that's called injury. But the Mercedes is still functional. It can drive. Conversely, if I just go out and take the carburetor out and do nothing else, the Mercedes will not move. It is dysfunctional. And the goal of the Mercedes is to drive. So we don't worry about injury, we worry about function. And the parameters to assess function are the AST, the prothrombin time. Those are the critical measures that you want. In addition, occasionally cholesterol is helpful because 95% of the cholesterol in your blood and body is made by the liver. So you can pick that up. But unless you have starting values, it's hard to determine those responses. So the issue is, don't let asymptomatic injury inhibit your treatment of the patient for its hepatocellular carcinoma. Now, if you still are undecided about what to do, you can always do a liver biopsy. And liver biopsies also help you distinguish between injury and dysfunction. Drug-induced hepatic injury is characterized by a mild hepatitis, or occasionally granulomatous hepatitis with ring granuloma. Drug-induced dysfunction is characterized by the presence of lobular hepatitis as well as a active portal hepatitis and endotheliitis. So it's a very different impression with a much broader scope of potential injury. Now, let's talk about these immune-mediated adverse events. As I've already mentioned, the most common are just fever and fatigue. But in certain cases, patients have skin, and the previous speaker showed you lots of examples of skin injury. Intestinal injury occurs with malabsorption and diarrhea, and a host of endocrine problems can occur with thyroid disease, typically hypothyroidism, adrenal insufficiency, pituitary insufficiency. In addition, one of the most severe is pulmonary involvement, which can potentially be lethal, and brain injury. And people develop severe encephalitis on occasion, and oto injury or hearing deficit has occurred, and an arteritis can occur, which can involve the cerebral vessels as well as the heart. Hematologic events occur, but occur less often than the things that I've already mentioned. So from the point of view of a hepatologist, me, when you would consider the use of immune checkpoint inhibitors, I think what you have to do prior to initiation of the checkpoint inhibitor is assess the serum levels of liver injury and function so that you have some understanding of where you started. And you have to assess for any evidence of current or past infection with hepatitis B, hepatitis C, HIV, and current COVID-19 infection, because these will all get worse with your immune suppression that you're planning. So you have to make your decisions at that point whether you want to move forward or not. During the course of therapy with immune checkpoint inhibitors, you have to assess the evidence for injury and dysfunction, and you do the ALT, at least on my recommendation, twice before at the initiation of therapy, and then every 2 weeks times 2. For evidence of hepatic dysfunction, you measure AST, and you can allow it to go up to 3 to 5 times the upper limit of normal, but you should check it at 2 weeks times 2, and then monthly. Use the initial dose or as low as possible to see that you don't have any problems, and you can progressively increase the dose with immune escalation on a monthly basis. So you want to move slowly. You start at your base level, increase, check it out, run about a month or 2, and then check it again. Additional recommendations are that initiate therapy with 20 to 30% of the dose utilized in patients that are not cirrhotic or have hepatocellular carcinoma, and certainly haven't had a liver transplant, because that latter group already has some intrinsic immune suppression, and you may have to correct for that with your therapy by adding more. You also want to make sure that there's sufficient allograft tolerance that contributes to total immune suppression, and you know that by the elimination of those various infections. You want to increase the checkpoint drug dose slowly, if no problems, after 2 to 4 weeks of therapy, and again by another 30% after 4 weeks more of therapy. At this point, further dose increases are likely to be adversely effective and produce allograft tolerance, adversely affect allograft tolerance. So if any concern arises about allograft dysfunction, the therapy should either be reduced or discontinued, and then pay attention to the function of the allograft. In summary, the oncologist has to understand not to panic if liver enzymes increase in an asymptomatic patient. This is really a signal of liver injury as opposed to function, and does not inhibit your continued treatment. If you have hepatic injury, it's dose dependent and will resolve with appropriate dose reduction of the immune checkpoint inhibitor, although ALT levels 3 times or less above the upper limit of normal are not required for any change in therapy. So it's only if it goes above 3 times the upper limit of normal that you have any concern. In contrast, AST increases 3 to 5 times the upper limit of normal, and its presence is associated with fatigue, a rash, fever, an abnormal prothrombin time, and a reduction in cholesterol levels from the baseline level, and mandates either a substantial dose reduction or discontinuation of the immune checkpoint inhibitor and or the initiation of prednisolone therapy to control the immune response. Now, because of the prohibition for the use of checkpoint inhibitors in allograft recipients, it's obviously also extended over to allograft recipients who have a hepatocellular carcinoma. And there are only a pitiful number of case reports of such, and most of them used not continued immune inhibition, but TACE or radioactive beads or some other or local therapy to get rid of the tumor in the recurrent tumor in the allograft. So we really don't have any real data, but based on what I've told you, I think there's no reason why you couldn't use or should use the checkpoint inhibitors, but you want to start slow and check them out at regular time points. And because the process can be slow, and you're starting with a new patient with a new liver with a tiny new metastases, you're not worried about the time that it takes to get to a higher dose level, because you're not talking about the cirrhotic with a big tumor and a shortened life survival. You've got this patient with a small tumor in an allograft liver, and time now is on your side rather than against you. And so you can use the immune inhibitor, but check the response or the consequences of any dose on a regular basis, and only respond if you have significant injury, not, significant dysfunction as opposed to injury. And that's essentially the nuts and bolts of my presentation. If you're going to treat a small recurrent tumor in a liver allograft, be brave. You can use, if you'd like, local therapies, but there's no reason why you couldn't use immune inhibitors. And I think they would work perfectly well. And because you're starting with a, quote, healthy allograft, you can escalate the dose up pretty well and not have any significant fear like you would in the cirrhotic who has the same tumor or a bigger tumor. I thank you for your attention. If you have any questions, please feel free to ask.
Well, very great talk. Thank you very much. And the message is that we don't worry to use the PD inhibitors in transplanted patients. And as I understand from you, it is better to step up than to walk down with the dose. It is correct?
Yeah, I think the issue is that a tumor in an allograft or a metastasis that arises in an allograft after a successful transplant is a very different situation than the cirrhotic with the tumor, which is what you normally see.
Absolutely.
Now you have a patient with no cirrhosis, a healthy allograft, and a small tumor. There is no reason to be frightened. What you can do, if it's depending on the location and size of it, use local therapies, alcohol ingestion, radioactive beads, all kinds of things that exist. But you can also use the immune inhibitors, and I think they would work substantially and add to the now current tolerance of that new liver, and you can destroy the tumor much more successfully than you were ever able to do in a cirrhotic, because you're starting from a very different baseline.
Thank you for your comment. Are there any other questions from the auditorium here?
Yeah, well, you monitor rejection all the way along, but the rejection, I think, is overutilized by transplant hepatologists and transplant surgeons. Any dysfunction is considered rejection. And I think that's not true. Many people receive therapy for rejection that don't have it just because the doctors feel secure in administering it, and they don't have any downside to doing it by and large. But I think if you're worried about allograft rejection, get a biopsy and prove it. It's only going to take you another couple of days and you'll have the answer. And if there's allograft rejection, fine, you can always cut back on your drug therapy. But my best guess is you're going to be astonished how rare that actually happens. And what you have is the response to the inhibitor therapy.
So that means the message is, don't worry about the best use of the best drug in the best condition.
See, again, just to reiterate what I said, don't respond to fear.
Yeah.
Respond to information. If you think there's rejection, prove it.
Prove it.
And the way you can prove it is a biopsy.
Very nice.
If the biopsy is negative, continue your immune suppression.
I see around no other question, David. Thank you very much once more for this excellent presentation on this excellent topic. And you gave new insight in this problem. And don't worry about the use of inhibitors in transplanted patients. Thank you very much for this message.